we'll move on to our first keynote speaker, Dr. Lynne Maher. And I had the opportunity to speak briefly with Lynne this morning. Lynne is the Director of Innovation and Design with the National Health System in the United Kingdom. Dr. Maher will speak to us about putting people at the center of care. Her presentation will share what's been happening in England with patient-specific based design, bringing forward specific examples, methods, tools, successes, and achievements. And she'll assist South West LHIN healthcare leadership in understanding the role they can play in patient experience-based design. Now, Lynne will do her presentation. She'll open up the floor to questions at the end of her presentation. And at the end of that, we'll also have some table discussion, which Lynne is going to help facilitate. So please join me in welcoming Dr. Lynne Maher to the podium.
Thank you very much, and I'm really, really excited to be here, especially to see such a full room of leaders from every level who are coming together for the purpose of improvement. It's really important to take the opportunity to network and learn from each other, and this sort of occasion is perfect for that. As Mike said, what I want to do is share with you our learning in England around working more closely with patients and their family members for the purpose of improvement. And, you know, we've had some ups and downs along the way, and I know from feedback, we listen to Canada, we watch Canada's tweets. Oh, and you'll see that I also tweet. I've just tried to tweet, but the signal's not very good in the room, so I'll make sure they go later. Tweeting is actually a very good way to see what's happening around the world. So I know some of you are already doing some fantastic work in this area, so I'm going to share our learning and let you think about that and see how that fits into your context here. One of the big issues we have is what we think about falling into the patient satisfaction survey as the only way we should really interact with patients and family members to understand how they feel about our service. And a couple of years ago, our Secretary of State for Health said this, basically saying, actually, as it is right now, our national patient survey is really not meeting the needs of what we want to understand how people feel about our services. And, you know, the last bit of his sentence in saying it's too much like asking patients if they're grateful. Patients should never, we should never think about asking patients if they're grateful for our service. We've got to ensure that they expect the highest quality and highest service for us, and therefore we need to truly understand what that looks like for patients. And we've got to get over some mindsets that are currently, certainly in some parts of our service in England, and I hear from others it's the same around the world. This cartoon's depicting an old-fashioned ward round where the senior consultant is saying, when we want your opinion, we'll give it to you. And that's not the way, of course, that we need to work. There's a big worry in England around patients coming to surgeries or coming to outpatients or coming to visit any clinician with an armful of information that they've downloaded from the internet. And, you know, the patient's saying here to this very harrowed-looking general practitioner, "I'm sorry, doctor, but again, I have to disagree." And, you know, in our system, we're just moving away from the fact that the clinicians, not only the doctor clinicians, but all clinicians are all powerful and have all of the expertise. Absolutely, they have expertise, but actually we need to move more towards a partnership to enable discussions with patients and family members more on an equal basis. One of the big worries around patients coming with armfuls of information is that there are some sites in our country that are not very good sites. And so patients are getting information that's not the most helpful. And we're starting to do something about that so that there's enough really good information for patients to look at before they want to go to any clinical appointment. And finally, in the big anxiety stakes in terms of working more closely with patients and family members, is this thought that if we ask patients what they want, we're never going to meet their expectations. And so there's another cartoon here which I'll read. So there's a clinician saying, or there's a hospital in Doncaster, which is in the north of our country, boutique style, ensuite, a la carte, organic snacks, and one cataract operation or one breast enlargement free with every hip replacement. Now, some of us might want that, but, you know, no. It is one of the biggest barriers to the work that we're doing with trying to work much more closely with patients. Staff are very, very worried and say, but what if patients want something that I can't possibly deliver? In our experience, that has never, ever happened. And we've been doing this work for nearly 7 years. Never, ever has it happened. The opposite has happened. Patients and family members identify points in the process that are not useful for them. We can take them out. They work much better. They take their medications better because they can understand how they're supposed to be taking them. Everything changes for the positive, not that we can never meet their expectations. We commissioned a report last year entitled What Matters to Patients, because we wanted to start to understand what themes we need to focus on. And I'm going to give you a website later on in the presentation where you can download this full research report to look at. We commissioned it from King's College Hospital Research Unit and the King's Fund, two very, very credible research institutions. And basically, what they found is the things that are more relational. You know, patients want to feel informed and they want to be able to give their opinion. They need to link with staff who spend time with them and listen to them. We want to be treated as a person and not a number. Or equally, in England, you might often hear people say, oh yes, Florence, the hip replacement, or Joseph, the appendix, or Sheila, the breast implant, or whoever. We tend to link patients with their condition rather than see them as a person. Being involved in their care and being able to ask questions, and the value of support services. And what this is around is integration. As was said earlier, break down those silos and support me through the whole of my journey. And at the bottom, efficient processes. I think what patients and family members really expect is efficient process, safe care. Actually, what they want and they're not getting so much as in our system is that relational aspect. We did another analysis of this report and we've been breaking it down because there are a few more points there in the report than I've shown you. And actually what's coming out consistently is those relational aspects are much higher thought of by patients than the actual technical or functional aspects of their care. And, it's really important that we focus on that. Now, one of the pieces of work that we've been doing over the past 7 years is trying to really understand what's important to patients and family members and design the system with them. And we've just called this approach the experience-based design approach. And this approach is really about using people's actual experience to be able to gain insights about what improvements can be made. It's not about opinions, it's not about attitudes, it's not about what I think as a clinician or as a manager. It's about really, really understanding the actual experience of the people who are going through the healthcare process. And I'm going to talk mainly about patients this morning, but we use exactly the same methods to understand the experience of staff delivering care, because of course that's important too. And we learnt a lot of these tools and techniques that I'm going to share with you, and these methods, from designers. And Patty's going to talk to you later around designers, but I have to say, in my very long career in the health service, and particularly in improvement, using this design methodology has been revelational to me. It has been the best thing that I've ever done, and given results much more important than any standard improvement methodologies. The trick is to use both, and use the design methods and standard improvement methods rather than either or. And one of the things we learned quite early is there is definitely some synergy between the way designers think and the way that healthcare organisations think. And you know, we've been doing a lot of work on performance, you know, how well does this process work in general performance and efficiency terms. We've been doing a lot of work around LHIN, but also with what designers might call engineering, that we would link to safety. How safe, how reliable is this process? And, you know, in England and here and many other health systems, we are focusing on that. When I looked at this learning from designers, I realized that actually the aesthetics of experience was something that we were playing with. We weren't focusing on, and that was an area of focus to us. A researcher who was working with us at the time, a gentleman called Paul Bate, who's instilled in health service research, actually had this reflection and said when he watches people do service improvement, they do one of three things. They don't listen to the users, and us in our clinical and managerial capacity decide what we think is going to work. Or we might listen to users of the service, but then we say, thank you very much. We're now going to look to see how that will work in improvement. We'll make the decisions about how to translate your experience into what we think needs improvement. And that's better than the first one, but it's really not good enough. What we want to do is link in more to the third one. Listen to the users of our service, and then work with them to improve that service all the way along. And, you know, the experience-based design methodology aims to help people do that. So we need to move from a service that does things to and for its patients to one where the service works with patients and family members to support them in their health needs. And that's the whole ambition. Now, what we designed as we were working with service designers is what we think is quite a simple 4-stage process. And that's about capturing the experience in a number of different ways. And this is the biggest section. And then understanding that experience. What does that mean? What does all the things that we're hearing mean? And then improving that experience with service users and their families, and of course measuring that experience. And I'm going to go through each quite quickly. In terms of capture, you know, you'll recognise throughout this, you'll know a lot of these things. So they're methods that you've used before, but this is about just helping to bring them together. Interviews, and that's not research interviews, it's more like conversations. Okay, when did it start? Then what happened? How did that feel? What happened next? So coaxing people to tell you the story of their journey. Storyboards, still photography, anything like that, and observation. Lots and lots of different methods to help understand the patient's experience. Little story about storyboard. A gentleman who'd been in long-term care, he'd got throat cancer, and had a long-term tracheotomy in and needed a humidification bib. He brought this storyboard in and was sharing it with staff, and it's about a visit to a farm show, which he loved to do. And staff said, that's really interesting. Great photo, but what's that got to do with your journey? And, what's that telling us? He said, well, I've been a patient here for over 5 years. Every summer in those 5 years, I've tried to get more humidification bibs. I am a farmer. I need extra bibs because when I'm ploughing fields, when I'm harvesting, I have to protect my tracheostomy. You are always difficult. You never want to give me any bibs, any extra bibs, because there's a ration or a quota. And I just want to share with you that you don't understand why I need the bibs, even though I've been telling you. And, that gave those staff really big insight. They thought they knew this long-term person. They had no idea, or they'd not heard when he was trying to describe to them about why he needed extra bibs. Lots of discussions and interviews with people, and this is a story about actually a primary care team who were quite rightly looking at how they could provide services that were currently provided in a specialist unit, trying to provide them nearer to the community, the client group's home. And there was a particular focus on people living with multiple sclerosis, and the primary care organisation wanted to move a neurology clinic nearer to into a community hospital to serve these people. Fantastic idea. The problem was the primary care unit said, actually, this looks as if it's going to cost us more money, and they asked us to come and help them to see if we could make it cheaper. And we said, sure. And the first thing we asked is, well, have you actually spoken to any of the people who you're wanting to serve, who are living with multiple sclerosis? And the whole senior leadership team said, no. Why would we need to do that? Said, well, have you asked them whether this is going to work for them? No. So I said, do you mind if we do? Okay. So we went out and went to people's homes and talked to them about their needs and talked to them about the proposal. Every single person said, that would be really bad for me. Really bad, because most of these people have other conditions and they're really smart about arranging everything to happen that they need to happen on one day in the hospital. Actually, by moving part of that service to another area, it would mean they need to go to the hospital for some appointments, and then they've got to go somewhere else for something else. And then they might have to go back to the hospital if they needed specific investigations. They said that would be really bad, especially those people who relied on their family a lot to get them from one place to another. We said, well, what would help? What's really the problem? Are you struggling with anything? They said, yes, we are. We really struggle because if we have something wrong with any of our equipment, our electronic wheelchairs, our beds, any of our equipment, it takes 3 to 4 to 10 days to get that sorted out. And can you imagine if you rely on a piece of equipment and it's not working well and you need somebody to come quickly and it takes up to 10 days? That's no good. Many of them said they were unsure about what services they could ask for and what finance they could get for support, so they needed help with that. Most of them said, we didn't know anybody was living in this community in the same way that we were with multiple sclerosis. We want to connect with them, and particularly the family members wanted to do that. And the other thing they wanted is to have access to support for work. They wanted to be able to do some work. Of course, they needed to work in a special way, but that was not being afforded to them. So rather than moving neurology services closer to them, which wasn't going to help them, we got the primary care organisation working with them and provided a little bit of funding to enable them to create a website that would link them in together. They called the website Enable, actually. They developed it themselves with a software designer, and they added in fast access to a handy person who would come and fix their wheelchairs. They got linked into support with finding work, and they got linked into social services who could support them with helping them to understand what they can apply for in terms of support. And that has made the biggest difference. And, you know, if they hadn't done that, a new service would have been provided that would not have been useful for that client group. We always also use these methods of storytelling, diaries, and film with staff. Like, for example, one of our series called The Productive Ward, and now it's embedded into every single thing we do. We're currently working with residential care homes, and you know there are people there who have dementia and Alzheimer's. We're working closely with the family members and staff there, and with the residents of care homes when we can. But everything is based on experience. We never ever do anything without first understanding from the person's point of view what this feels like. Observation is a tool that service designers offered to us, and I'm an intensive care nurse by profession. And when this lovely designer who we were working with called Deborah said to me, "Okay, Lynn, I'm going to teach you about observation," I have to say I was a little bit skeptical. You know, I said, "Okay, I've been an intensive care nurse for rather a long time, and I'm an expert in observation." And she said, no, you don't know what I'm talking about. And what she taught me was the way I was observing, which was necessary from a clinical perspective, is looking at signs and symptoms and linking them to some sort of diagnosis. So I was really, really focused on that. From a service designer point of view, we're trying to understand the challenges, and we're observing to try and get inspiration. We're trying to understand what really, really goes on. It's like taking a step back, even if we're working in a clinic or somebody's home that we've been into hundreds of times. We have that expression, you can't see the wood from the trees. And service designers taught me to observe in a completely different way. We also did a little bit of work with a larger company called IDEO, and they know I've stolen this quote from them, and I represent them because this really, really comes true every time. People do not always do what they say they do. They don't always do what they think they do. They don't always do what you think they do. They can't always tell you what they need, but often when you're observing, you observe workarounds where they're fixing something to make it go better. And if you say, well, do you need anything? They say, no, everything's working pretty well. But you can see things like workarounds, and observation really helps you to find out what is happening. And we never do anything without doing some observation first. We just go and sit and observe. And just an example of this, we were observing in a ward area that was looking after people who'd had cerebral vascular accidents, strokes, and we're observing just generally. They wanted just to improve, and so they're trying to understand what could be improved. And I was observing, and we saw a nurse go and talk to a patient who was sitting in a chair, and she was going to be discharged home tomorrow. She'd done really, really well. Still had a little bit of a walker to help her, but doing really well. Nurse went up to talk to her and said, "Oh, you're going home tomorrow, which is great news, but you know, you're not drinking very well today, and I need you to finish this jug of water today. Otherwise, we might not let you go home." It's what nurses do. We give you a little veiled threat there to make you do something. And anyway, and the nurse was doing it with absolutely the best intention because it's important to keep fluids up. Anyway, so the nurse bustled off, and we were just observing, and the lady who she'd just been talking to burst into tears, really, really upset. And in true observation, I've been taught that you shouldn't go and interfere, but I don't do it properly. So I went and interfered and said to the lady, "Oh, you know, what's happening? Do you not like the water? Can we get you some tea? Because in England, tea solves every problem you ever have. Or juice or something." She said, no. And I said, what's the matter? You're doing really well. You're going home tomorrow. And she said, "Not if I drink that water." okay, so you tell me a little bit more about this. She says, if you make me drink that water, I'm going to die. So I'm thinking the lady's got confused and that she thinks somebody's poisoned the water. So I said to her, do you think somebody's poisoned the water? She said, no, don't be ridiculous. Okay, I'm trying to keep up with you. And she said, so I said, tell me more. She said, my friend in the bed next door, she was going home 2 days ago. She drank the water. She went to the toilet. She fell. She broke her hip. They operated. She died. I don't want that to happen to me. So I'm like, okay. Said, you're not going to die, even if I have to stay with you the whole night. Said, let's go to a walk to the toilet to find out what's happening. So we went to the toilet and I said, pretend you're going to the toilet. So she did while we were observing, and this lady got a deficit on her right-hand side. The toilet roll holders in every toilet on that ward were on the right-hand side. When she reached over, people who've had strokes often have imbalance. She felt she was going to slip, and she'd almost slipped a couple of times, so she had that in her memory. And so it was clear that that was a problem. So we then went to look at the ward record for falls in the toilets. 90% of them occurred with people with a deficit on the right-hand side. We went to the chief exec and said, look, this data's been staring you in the face and nobody's recognized what's going on. And we told him the story of the lady and said, you need to do something because you need toilet roll holders on both sides. That afternoon, there was toilet roll holders on both sides, and the falls rate over the next year disappeared completely. And, you know, that data had been there for a year. The addition of the story through observation made the difference to not only protect people from falls, but also save a lot of money. So working with patients definitely saves money as well as increases quality. For people coming through in short stay areas such as the ED, outpatients, day surgery, sometimes it's quite difficult to do more lengthy conversations or diaries or storyboards. And so we devised a thing called an experience questionnaire. Now, the thing about this is it's quick and easy for people to use. You can gather them in large volumes, but it's not just looking at satisfaction. It's still looking at patients' experience as expressed by emotions. And we often use it as a bit of a starting point to understand what's going on, and then use deeper techniques such as interviews, storytelling, narratives, that sort of thing later on. And you won't be able to see this very well, but I'm happy, I'll send a version of it out that you can all access. And what happens here is you have a process steps at the top, and you can change those process steps depending on the process that you're going into. This just happens to be day surgery. Underneath the green process steps, you've got some very, what we call light emotion words, and these were chosen by patients, going from kind of happy to sad, and everything in the middle. And then underneath that, you've got a box where patients can write something themselves. So the idea is they come in, you talk to them about the questionnaire, let them have the questionnaire, they keep it as they're going through their process, and at each step they either circle one of those emotion words or write something in the box if that emotion word it doesn't reflect how they're feeling. So we're trying to understand how they feel. And this is one that's been completed. And this is a gentleman actually going through day surgery. And even on arrival and check-in, you'll see he circled worried. And then he changed his mind and he decided he was very scared and wrote that in the box. But you'll see there's a mixture of circling the words and writing. And if you do gather these, you start to see trends of where people are most anxious, where the service doesn't meet their needs, where they feel emotionally negative. And you see where they feel emotionally positive as well. So absolutely all these stories have positive and negative elements. So I'm going to send that to you so that if anybody wants to use it, they can. We use those emotions when we're understanding the experience and we're really trying to bring the themes together. So we absolutely, through every element of storytelling, storyboards, pictures, the experience questionnaires, observation, we use those emotion words and we link them to points in the process, in our standard process mapping, and we call that a touch point. Wherever I have a negative or positive emotion linked to a point in the process. And we look at those and look at the themes and then work with patients and carers to be able to identify where we need to improve and where there's positive emotions that we can learn from. Now, what we typically found when we were starting to use our traditional process maps and then map stories and emotions on was that we think in our silos. So we might think from the start of an outpatient appointment or start of coming into a clinic or hospital or anything like that. But the patient journey starts way before that, and it ends way before they walk out of our doors. And so that gave us a really good insight into the fact that we need to understand the whole journey and work together to integrate care so that people didn't feel lost in between one healthcare sector and another. And in our system, one of the biggest problems is parking. And so what we found was lots of frustration comes out when people are trying to park their car, and signposting. They can't find out where they want to go. And by the time they come actually and get into the healthcare facility, they're already frazzled before they even get to us. And so, there's a lot of emphasis now about actually how can we support people's health from the moment they leave their journey, well, even before they leave their journey from home, if we've given them information. So it really identified that we don't look at the whole journey from the person's perspective. Now, I'm just going to show you a short film of a lady called Sheila. She's got a quite quiet voice, but she's telling her story, and I want you to listen for words that might depict emotion. And then just write them down, write every word down that you think would depict emotion. So just listen, because she starts quite quickly and she's got quiet voice.
In ENT.
The words at the beginning of that, you'll see we have cut bits of film together just to illustrate this, but I think Sheila's story and the words that she uses really does illustrate that whenever you're listening to somebody's journey, it is never all negative, and this is another fear that people have. There is always a balance, and at the beginning of her journey, I mean, you wouldn't want to be providing any service that somebody would describe as dreadful and, it filled her with horror. Now, that was just walking into a waiting room. Now, when you expanded the story with Sheila, what that was about was Sheila was coming into a cancer clinic, and it was a head and neck cancer clinic, and what she saw was people, she was going in as a new patient, and she was mixed with people who'd been through surgery and had, severe facial disfiguration and neck disfiguration because of the surgery. And at the same time, the waiting room was shared with an orthopedic clinic. And that's what she was describing with those very strong negative emotion words. And the waiting wasn't good. But then when she started to interact with the healthcare professionals, her voice changed, her words changed, and the whole demeanor changed, especially when she met Mr. Chan. She loved Mr. Chan. Mr. Chan was a very, very lovely consultant who, went and holds people's hands and is really strong on those emotional aspects, and that absolutely turned her journey around. After this appointment that she was describing, we said to her, how would you, if you were rating us, this survey now between 1 and 100, how would you rate it? And she said, I'd rate it 99 at least. We said, but Sheila, what about all the terrible stuff that you were describing earlier on? She said, but that was all made right when I went in to see Mr. Chan. And we find this a lot. Actually, people can cope with, we don't want them to cope, but what happens is they can have a very negative experience, but then if they are shown kindness, respect, empathy, and shown that there is a partnership here, actually they would rate you very, very highly. So, you know, that's important. If we focus on those good things, we are meeting the needs of the people we serve. Of course, we have to sort out the process things, but this sort of storytelling gives us a real insight into how people are feeling. That clinic had been like that. That outpatients area had been like that for about 5 years. You know, nobody ever mentioned it before. It was never in any complaints before, but actually the storytelling made us observe again, and the clinic got changed so that new patients, there was a separate new patient clinic so that they weren't mixing with people post-surgery. So, you know, we use a lot of videotape to be able to share things like this. And one of my experiences is, you know, typically if you want to undergo major change in an organisation, sometimes it can be hard to persuade people to come along with you. You know, they're too busy, the service is good as it is from their perspective. You show a film like this, job's done. You know, people just say, okay, that cannot carry on. Let's do something about that. What shall we do? You know, how can we get on and do it? It is really compelling to be able to show film. And I just want to say, Sheila does know that I use her film. Sheila's given us permission to use her film around the world for the purpose of sharing improvement methodology. And I normally send her a little note back to tell her where I've been, or I send her a postcard and say, you were in Toronto or Stratford today. So she'll be very happy because she was in New Zealand 2 weeks ago. We've captured the experience. We've looked at how we can start to really understand by looking at those emotion words and linking them to points of the process. And now we need to improve that experience. And again, this is about improving with the people who we're working with the patients and family members, not just us as clinicians or managers going off and saying, oh, you know, we've got all the information now, we're going to redesign. And the big thing here is that we use typical and standard improvement methodology when we need to, but the big difference is what we call the co-design event or experience event, and that is bringing people together at an event, and that might be 10 people and it might be 100 people, depends on the context. The big thing here is that if we're asking staff to come to an event, often we can get away with giving them not that much notice. But when you're working with patients and family members, you really have to respect their life and outside of what they're helping you with, and you have to plan these events very well in advance. You have to be really clear that we don't use medical jargon and use what we call the phrase simple English throughout the event. And what surprised us in the early days was the amount of support staff needed. You put in staff into a really difficult position where they're used to having quite a lot of power and autonomy, and you know they're in this role where they're the supporters, and they need to now be in a role of true partnership. And you know, often we've had to facilitate table discussions quite carefully when it comes to staff and patients, because staff just want to take over and they want to make it all better. But this is about a true partnership. Also, we needed to recognise that actually working with patients and family members means that you've got a really good gift, because they come not only from their experience perspective, but from the perspective of their working life, whether they're a mother organising 4 children or a nuclear scientist. You know, we learn from them, from their perspectives, and you know, we call that bringing a fresh eyes approach, and that's made a real difference in terms of some of the solutions that have come out to the problems. And it's not only about working in partnerships with patients from the clinical process perspective, but throughout the process of any project. So, for example, if we were doing an improvement project and we had an event, we'd write it up on sheets of paper and put bullet points and make a table about who was doing what. No, the patient said to us. The gentleman at the top, Hugh McGrath, was a patient who worked with us, and he said, in my industry, he was a customs officer. He said what we did was attach our photo and we hand wrote our actions to and attach the actions to the photo, and that makes it much more meaningful. Good grief, it does. You do that and put that on the wall in the area that you're working, and it makes a big difference. These are all also loaded onto an intranet. So every person writes out their actions, be it patient, receptionist, consultant, and they're all put on the wall. So it's about working in true partnership throughout the project. So, and then for improvement, you just form project teams as we would, but we've had patients leading project teams as well as patients being part of project teams. We help them to understand our improvement methodology, such as Plan, Do, Study, Act, and we take other methodology from them as well. So true partnership all the way. In terms of measurement, which is the last section, this is interesting because we got really tangled up in measurement of how we really use it, and we're still a little bit tangled. But I think what's coming out is actually you use your standard measurement approaches, always baseline, always think about what parts of the process that might be being improved. That might be timely appointments, access, safety, number of complaints, all those things that you would normally measure, but not to forget the emotional side of things. I like this quote from Daniel Pink. What matters more than raw data is our ability to place these facts in context and deliver them with emotional impact. Remember the story of the toilet roll holder? The raw data was there. It didn't make a jot of difference to what happened in that area until we put the emotion and the story together, and then that made a massive difference. And Paul Levy, a chief executive in America, talking about safety, and he was asked a question about a percentage of safety, and he said, actually, yeah, percentages are good, this sort of data measurement is good, but we've got to think that we are dealing with humans. So the main message here around measurement is absolutely use your improvement methodology measures, but make sure you also link in with the storytelling, the before and after, the emotional mapping, and see how that changes. What we learned from our experiences is that we absolutely have bust the myth that patients want what we call a gold-plated experience. That's never happened in our experience. They want high-quality, safe care, and they want to be treated with respect and partnership. They want a good experience from start to end. What we've also learned is patients and staff see themselves in each other in a completely different way. And in long-term facilities, the interaction is much more rewarding and there's much more appreciation of each other. And actually, confidence for improvement action has grown for all, and particularly on the staff side, once they get over the fact that this is a partnership and it's a different way of working, they really do enjoy it and have found that they go home saying, actually, I've worked really well. In addition, patients and family members often take on some of the tasks, like rewriting information, so they become part of the workforce, which is really important. Leadership, you will not be surprised to know, is absolutely critical. And in the research report I mentioned earlier, there were two main attributes, and that was around visible leadership and organisational culture, which often comes from visible leadership. And this were the main attributes of those organisations who are not only collecting the data, but then using them to improve. And so now I'm going to just give you a few minutes for a table discussion and which will add on to the table discussion that you have later. I want you just to think on your tables for a couple of minutes whether your organisation has a clear strategy to learn from patients' experience and to work with patients and users to improve services, and then think whether you've got, or you, the very senior leaders in the room, are going to put any resources into this. So I'm just going to give you 2 minutes to have a quick discussion on that, and then I'm going to call you back before I finish. Now, I'm going to ask somebody or two people to be really brave. And if anybody has a strategy and has started to put some funding around that, would they mind sharing that with us by coming to one of the microphones into the middle of the room? So I'm going to be very, very disappointed if out of all the organisations in this room, there is not at least one or two who've even got an emerging strategy. So anybody, oh, thank you. Would you mind saying who you are, where you're from, and then sharing that with us?
Sure. I'm
Thank
Michelle Hirschbies. I'm with London Intercommunity Health Centre. And what I shared with the table is, I think, in one component of our organization, so as a community health center, we provide a broad range of health and social services. So one of our programs is funded under Aging at Home. It's called a wraparound program for immigrant and isolated ethnocultural communities. And so it is actually all about sitting and listening to the story. And as you hear the pieces from immigrant seniors who frankly aren't accessing a lot of other services because they don't have English or French, and the system doesn't make sense to them. And so actually hearing their story about what they need and looking at all aspects of their care, so you might actually access in a health system, but what they've identified is that they've actually completely disconnected from their faith. And you kind of go, I don't get that the fact that they're not connected with their faith has to do with keeping them at home. But in fact, listening and putting that perspective and spending that time listening to the stories, not the health status, is actually what shapes that patient experience. So we actually do have resources and templates and have shifted services and shifted approaches related to doing that. We struggle much more in the primary care aspect of my organization, but in that component, there's a very clear strategy that impacts on a whole wide range of services that have shifted and changed.
Great. Thank you very much for sharing that. That's a great example. Now we have another brave soul. Thank you.
Only brave because we realized a while ago that just how disconnected we were as executives and as staff in all our planning to our patients. I'm a VP at Community Hospital, St. Thomas Elgin General Hospital. And we've been on LHIN journeys and other journeys, busily doing this, busily doing that, all for the good of the patients whom we believe that we serve. But it never really occurred to us, certainly as executives, that we should actually go and meet and talk to our patients. For myself, I'm not a clinician, that was a scary and frightening idea. I mean, I could talk about it theoretically, I could read your stuff on the internet, which I have done, but to actually think with some of our team that we should do this, I mean, we certainly rounded amongst our staff, but to actually go into a patient's room and say, hello, my name is Malcolm Hopkins, is there any, how are things going? Is there anybody that maybe we could recognize, anybody serving you well, or just what? And I think, goodness me, what would this be like? But in a sense, for myself, I had the privilege of, my mother was a nurse, a very brilliant nurse, and I learned a lot from her, and I was privileged to watch her die and be with her dying. And that moved a lot of barriers for me personally, to know how important that was for her that I was there. And I kind of thought the same thing with the patients as well, that they were scared and frightened, probably more so than I was, in going into their rooms. And so we started to do that. We've made a commitment that as executives we would try and see at least 2 patients a day get out of our rooms.
Wow.
Have we got there yet? I know my CEO, Paul Collins, is over there, and he also, with trembling and fear, has started doing this as well. But our perspective is changing, and we're in the middle of sort of doing a lot of design and what have you, and we stopped thinking so much of what we're doing for the patients and how kind and nice we are, and I hope we are, but actually to listen to their voices and to stop being afraid of them.
Yeah. Fantastic story. Thank you very much. Thank you. And we have one more.
I just wanted to share a story. I work in a family health team in Goderich, and we pride ourselves on being, cutting edge and trying to incorporate improvements in primary care that we learn about. One of them is advanced access, and we've been working hard to do that in our facility. Part of that is going to mean a reorganization of the way we provide care for diabetics, because our diabetic nurse educator is so overwhelmed that visits are 2 months out, and that's not good. So we're thinking group visits, we're thinking all sorts of, all these buzzwords that we learn, we're trying. But nowhere in our plan to reorganize this have we thought about sitting down and asking diabetic patients what they'd like. So I appreciate your comments. I'm going to go back, and I sit on the quality committee, so I'm going to suggest that we do a work group and see what people would think of this reorganization. So
Yeah.
it's simple. It's so simple that we didn't do it.
Yeah. Thank you for that. Are you going to share? So we'll have you as the last sharer.
Hi, I'm Ann Alexander, and I'm on the board of Participation House Support Services in London. And we serve individuals with physical and cognitive disabilities and help them stay in group homes. We have something called the PAR process, which is our participatory action review. And as a board member, this helps us personalize the people that we serve. I'm an accountant by background, and everyone will tell you I look right at the details and the numbers. And a process where you actually look at the background of the individuals and their personal stories is extremely helpful. I enjoyed your presentation, and what we'll take out of that is that perhaps we will now have to go into our homes and observe and look more closely at the experience of the people we serve and put together my details and, as you said, the emotions. So it's been very helpful. Thank you.
Thank you very much for sharing. Thank you. I would absolutely urge everybody, and this does feel a bit scary for some people, because we've not really done it before, but actually once you do it, it is really, really rewarding. So thank you for that. I mentioned that I would just give you a brief update into what's happening now and share with you the website address that you can download the What Matters to Patients report, but lots of others. So the top part of this slide that says Transforming Patient Experience, that's a website. It's at the bottom, just the Institute website and the guide at the bottom. And what happened was we found that there was a lot of information starting to scatter around the National Health Service. So what we've tried to do is pull as much of that information as possible into one place. So if you go into that website, you'll find lots of examples, lots of case studies, lots of tools, including the experience-based design tool and others there for you, free to download. The next piece of work that we've just started is called the Patient Feedback Challenge, and this is around really understanding how we can move from where we've got islands of excellence, we've got people doing so well using patient experience to help with improvement, and then all around them is what we might cruelly say a sea of mediocrity. What we want is for everybody to be doing patient experience. So our Department of Health have awarded some funding to support us to support people on the front line. So we're getting people who are doing this well to partner with people who want to learn and creating core groups of people to work together so that in the next year we'll go from scattered excellent practice to excellent practice that is right across England, if at all possible. So what we're asking people to do, that bottom website is a highly interactive one where people have got to post their excellent examples, and they've got to get lots of people to like them before they might be awarded a financial prize and be allowed to work with others. So we're using kind of social networking facilities, and we will be picking the people who've got lots of people to say, I like this and I want to work with you. So again, you can go and visit that site. You can log on. You'll have to register, but you can log on and see the case studies that people are putting up. You can see the comments that people are writing, and you can see how we're progressing as we go through. So we'll be continually putting information up on there. So hope that's useful. So I'm coming to the end of my presentation now, and I just want to leave you with this thought. And it starts with the experience-based design approach. You can use any approach you want to use as long as you work with patients and family members, not only to capture and understand their experience, but to work with them to improve the experiences of health services so that we together design better experiences for our patients and family members. And just before I go, Christina's asked me to show you the prizes that you could get if you get your passport all signed up. Just as a tempter. So one is our book called Thinking Differently, and it describes a process and lots of tools to start you from saying, oh gosh, how am I going to think differently about delivering my service, and get from that thinking differently to identifying ideas, selecting ideas, testing and implementing and writing a business case. So that's one of them. One is a book around leading large-scale change. So any whole health systems or large health organisations might want to try and win this. So it gives you a step-by-step guide around the leadership responsibility and frontline responsibility for getting change to happen at scale across systems or in organisations. And then two more which are exactly the same, and one is a copy of the Experience-Based Design Guide, which I've just been talking you through, and then a sister book called Concepts and Case Studies. So this goes into the basic concepts that we've stolen with pride from service design agencies and shares some case studies, and there's two sets of those. So I hope that encourages you to make sure you get your passport signed to be able to be eligible for these. So that's the end of my presentation. I'm going to open it up for a few questions if anybody would like to challenge me or ask for further clarification or just ask any questions. Thank you very much for your attention. If anybody's got any questions, come to the mic. We're all running away. Something I said, oh, thank you, you were going to the mic. Thank you.
My question is built on, I think, the work that you just described, which is absolutely awesome. I have about 30 years as a health planner, but did start out as a nurse and was astounded by your example of the toilet paper roll. Over my years as a planner, certainly there have been a number of examples where we know individuals and organizations want to put people at the center of their care, but there's so many things that get in the way. And I'm currently both angry and appalled about a situation where funding for a new service in my particular community was approved at least 7 years ago, and we still don't have service on the ground. I was involved in developing an initial business case for that. And to my knowledge, that whole business case was set aside and a new process undertaken. So my question is really, A, that money is still not going to service because of how our system sometimes works. And in your other work where you've talked about quality, do you have ways of saying, come on guys, we got to get past some of this. We've got to learn how to do this differently.
Thank you for that question. Really easy one, isn't it? Not. It's really hard, and you know, I'm very fortunate that I'm able to connect with a number of health systems around the world, and I have to say what you're describing, people describe everywhere around the world. One thing that I would say that in England has been very influential in breaking down some of those barriers is actually using the patient experience and sharing stories and actually taking videos. So when we were first working in this way and we wanted to influence people, we sat them down in front of videos and was saying, okay, this is what it was like, this is the difference it could make, and this is the difference in terms of impact of quality, safety, and cash coming out cost, because you know we've got to respect where people are coming from. You know, in England we've got to take £20 billion out of our system by 2014, and you know what we're saying is working with patients can help us take that money out, and there's evidence to say that. So it might be worth a try to reframe and use different influences and put the patient in front, because they are really powerful. So good luck with that, and thank you for the question.
Thank you.
Lady in the middle.
Yes, hi. So one of the areas as I was sitting here and struggling with, and I recognize it's perhaps a bit of a trust issue, but when we've been looking at some of our high emergency room users in our primary care setting, are our clients who are struggling with addictions. And when we start the conversation about what they need, can't get beyond, if you would just give me my prescription for list the narcotic, then it would all be fine. And that's not actually what we, so I know we're missing something, but we can't shift the conversation beyond that. And so how do you engage in a different way? And then so this isn't about the hip or the toilet paper, these are heavy-duty addiction issues.
Do you start the conversation with them when they're in your facility?
Yeah, sometimes that's part of the engagement when they're in our facility.
Often what we found with people who we might categorize as hard to reach is it's because if we're trying to reach them when they're in our facility, they are on guard, they just need the one thing that they've come to the facility for, and they are not going to engage in anything else. They want to hide back, and we find that quite a lot with some people who are minority communities in our system and the homeless people. And so what we try to do is go and find them in their community wherever they are. And that might be talking to them when they're in your facility and then saying, look, you can really help us here, and you might not want to talk here. Can I take you to Mcdonalds, or can I take you for a coffee somewhere, or because they often don't want you to come to their home, or is there somewhere where you go and we can talk to you? And that often unlocks people.
So I think we do that too, and we actually have some really good examples of some that I think, particularly the partnership that we have with the Vulnerable Persons Project, and our physician is actually working on the street with street level involved sex trade work. But I think in looking at the broader sort of some of those pieces, and just, I mean, so I think we're doing that, but we can't keep circling. We keep circling around to I just want my drugs and trying to shift that. But they are the clients who are struggling with that are some of the most challenging for us in terms of managing emergency room diversion.
Yeah, and I think, so you're already doing the things I would advise, but also what we've got to remember is some hard-to-reach groups just don't want to. And we've got to think differently about how we get to them. So it might be through other routes, it might be through in England we have social workers, so it might be through those or any other groups. But sometimes with individuals, you can't force them. That's ethically irresponsible, and sometimes we might not just be able to break through. But quite often what we find is if you persevere, somebody will talk to you eventually, and it might not be on their first visit, but if they come again and again and you're asking them the same questions the third time, they might just be so fed up of you they want to give in, but they realize that you really do want to know and that you might be doing something with it. So I would absolutely say try and persevere, but a tricky problem. Another question.
Yes, my name is Cynthia Crothers. Currently, I'm a care and service manager for a healthcare agency. Previously, in another career, I was in business before I went into nursing for over 20 years. And many of those years were spent in operations, doing the business analysis and centralization and redesign and all of the things that you're talking about bringing into healthcare. And we had certain models and formulas, you know, here's a task, and how many seconds, minutes should it take the average person to complete this task, and then I can calculate, you know, my full-time equivalent and come up with my staffing. Yeah. Coming into healthcare from business and wanting to leave the business model and come into a caring world, I find myself so frustrated with different agencies that I've worked in and for and with, because it seems like the business administrators have come in with these task models and tried to enforce that around a caring task. Mm. So, you know, my whole thing about doing my master's is going to be what can I come up with as a care factor when I want to create a full-time equivalency in a caring field? Because I just see that caring's gone out of it because we're so task-oriented, we're running like crazy, we can't get our heads up out of the work to do the caring that nursing is about. This, what you're doing, is absolutely wonderful because you're forcing top-down as well as grassroots to get back to caring and bring that into healthcare. And I applaud you because I think you're the new Florence Nightingale. So thank you.
Thank you. Thank you very much. Thank you. Just to respond to that, you're absolutely right, but I think both can go hand in hand. What we've found is, you know, over the years, just because of how things have evolved, we've got very focused on tasks, and actually we need to relook at that, and that's part of the work we do with, you know, for example, the productive ward. What are the tasks nurses, other clinicians are doing that we need to do, that might be necessary, we need to do them with the best ability and with speed so that we can release time to care. And actually, we found that you can look at both really effectively, and that's the thing that we're pushing. So that's the end of the questions and answers. I am around at coffee and at lunchtime, so if anybody would like to talk to me, that's great. But I am going to leave you, as Mike said earlier, with a task of having some more table discussion before your break, and so you've got to talk a lot about these because they're really important topics, and you've got to talk loudly, and you're not allowed to go for your break until Mike tells you to stop talking. So I'm going to leave you, and I'll come and wander around the tables to listen to what you're saying to make sure that you're on task. Thank you again.